Make it ano na siya, May. Make it ano na siya, May.
Kita naman, Dok.
Make it ano na siya, May.
Kita naman, Dok.
Good morning, everyone. So link for the attendance sheet will be posted in the chat box. Good morning, Dr. De Guzman, and to my advisor, Dr. Abad.
Good morning.
Good morning, doctors.
Good morning. Shall we start?
Doc, we're just waiting for Dr. Fabila and Dr. Cobo and other consultants.
Okay, thank you. Ay.
Good morning, Dr. Fabila. Good morning, Dr. Obligacion.
Hello, good morning everyone.
Okay lang daw akong sound, Doc, no?
Yeah, loud and clear, Dr. Palco.
Thank you, Doc. Good morning, Dr. Jacobo.
Good morning.
Doc, shall we start, Doc?
Okay, sure, pwede man.
Good morning, everyone. Welcome to my mortality review.
The purpose of the Mortality and Morbidity Conference is to provide a safe venue for residents to identify areas of improvement, promote professionalism, ethical integrity, transparency in assessment, and improving patient care. The Mortality and Morbidity Conference also provides a forum to teach the curriculum on quality improvement, medical legal issues to residents and students, to foster a climate of openness and discussion about medical errors. Today, Dr. Martin Frederick Palco will present a case of a 42-year-old male who came in due to altered mental status. Face by face, he will be highlighting the best practices based on the current recommendations and compared to the actual management of the patient, facilitating learning to each one of us present here. The ultimate goal of today's activity is that we will be able to learn from the mistakes on our part. We will also summarize identified issues and make a recommendation based on the problems identified. Before we proceed to the presentation proper, may I cordially invite everyone to a moment of silence for an opening prayer to be led by Dr. Celestina Ray Monroy.
Lord, let us all put ourselves in the holy presence of the Lord. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. Lord, we gather here this morning to enlighten our minds and learn from our mistakes. We thank you for the gift of friendship, for without our companion, we may falter in seeking help. We thank you for bearing us nourishment, for without your daily bread, we may succumb to exhaustion and fatigue. We thank you for the courage and strength for without solidity, we may never be able to face our patients. We humbly ask for forgiveness on our patients, their folks, and the caring community behind us. I earnestly ask for your company in times we need a hand to heal. I humbly pray for your daily bread in times our patients are getting weak and frail. And I faithfully ask for fortitude for our patients' families and friends to whom our patients rely on for our health. This I lift up to you, our Lord. Amen.
For my objectives of today's activity, discuss the case of a 42-year-old immunocompromised male who came in due to altered mental status. To discuss the differential diagnosis of patients who came in due to altered mental status. To discuss the course in the ward from admission to demise, and discuss the factors which contributed to demise and the recommendations to prevent further errors. This is the case of patient GNV, 42-year-old male, Filipino Catholic from Concepcion, Iloilo, who was admitted last July 29, 2021 with chief complaint of altered mental status. History started 9 days prior to admission. Patient was seen on the ground, unable to get up with left-sided weakness and disorientation. He was brought for a consult and was requested unrecalled labs. He was advised admission, but still undecided. 7 days prior to admission, due to the worsening of symptoms such as increase in sleeping time, disorientation, and flat affect, opted admission. OPS NPS for COVID-19 RT-PCR was requested and noted negative result. 2 days prior to admission, patient opted admission at the local district hospital and was managed as stroke in the young versus meningitis, bacterial versus viral, to consider immunocompromised host. He was started ceftriaxone 2 grams IV OD, metronidazole 500 milligrams IV every 6 hours, and dexamethasone. Due to the unavailability of CT scan and other diagnostic modalities, patient was eventually transferred for further workup. Patient is non-hypertensive, non-diabetic with no previous hospital admission or surgical operation. There was a note of hypertension on the paternal side. He is non-alcoholic, non-smoker who designs gown. He lives together with a male partner and has active MSM. During physical examination, the admitting resident noted the following pertinent findings. The patient was received GCSE 2 V1 M6 GCS9 in cardiopulmonary distress. Our patient has presented with altered mental status. It is a general term used to describe various disorders of mental functioning ranging from slight confusion to coma. Given the vagueness of the term, it is imperative to understand its key components before considering a differential diagnosis. Fundamentally, mental status is a combination of the patient's level of consciousness, such as attentiveness, and cognition, the mental process or thoughts. Patients may have disorders of one or both. For example, patients with meningitis may have impaired consciousness with altered sensorium and decreased attentiveness, but still with intact cognition, whereas patients with dementia may have a normal level of consciousness with impaired cognition. However, more frequently, like on this case, patients exhibit altered level of consciousness plus cognition, a relatively common and sometimes fatal cause of AMS. An observational study conducted in the emergency department found that a patient presenting with an acute altered mental status was the primary reason for the visit, for about 1% of all adult patients and 2% of older adults. About 40% of patients were aged over 60 years. 35% of cases had a neurologic cause. So it could be stroke, traumatic brain injury, or seizures. Acute alcohol intoxication, infection, and metabolic abnormalities were other common cause of AMS. Mortality was almost 25%, and the mortality rate increased if altered mental status lasted longer than 3 days. In this group, infection and neurological disease were the most common etiologies. Knowing this very important epidemiological data, our investigation towards the cause of an altered mental status should focus in this given information. At this very point of time, it is very important to dissect and investigate whether the admitting resident's approach towards determining the cause of altered mental status is systematic and appropriate. Initially, determine a baseline level of mental status or cognition and establish the rapidity with which changes have occurred. This often requires the assistance of a third party, such as relative, spouse, or friend. The admitting resident performed this. Questions should be targeted at establishing recent events such as trauma, relevant past medical history, previous medication use, and other alcohol or toxins. And every body system should be assessed in an attempt to localize the potential etiology. If we review the history of this patient, most of the information cannot be found in the history sheet. It is imperative to establish a baseline cognitive and functional status before the onset of the symptoms. In most cases, a previously obtained assessment of cognition can also be compared with the current screen to determine whether symptoms related to cognitive changes are acute or chronic in origin. Comorbid conditions, particularly neurological diseases, cardiovascular disease, and history of renal or metabolic disease should also be reviewed. And this was performed by the admitting resident. The pain levels, the presence of severe pain is often associated with AMS. Chest pain radiating to the arms, back, neck, or jaw is typical with MI, although chest pain may be absent in older adults and people with diabetes. The admitting resident was not able to elicit this as the patient is non-responsive. Non-specific irritability, together with typical symptoms of sweating, palpitations, weight loss, might suggest thyrotoxicosis, and the admitting resident was able to elicit this. In the physical examination, possible helpful findings include sign of head trauma, icterus, hydration status, dry mouth, beaten tongue, nuchal rigidity, heart murmurs, and abdominal tenderness. Pupillary response might suggest drug intoxication, drug withdrawals, or stroke. In this case, the admitting resident was able to perform this. Vital signs may be particularly revealing, and it was also performed. The signs of the meningeal signs, the neck stiffness would indicate meningitis or encephalitis, and it cannot be found in the history sheet. The lung examination would show decreased breath sounds and rust, which may indicate infection or diseases commonly associated with hypoxia, such as congestive heart failures and COPD. Given the cues noted at the history taking and physical examination, the admitting resident's impression is CNS infection, bacterial versus TB meningitis, to rule out CVD, to consider immunocompromised host, COVID-19 suspect. Patient was admitted and plans were carried out. Baseline and other pertinent labs were requested. Medications were started as well as other non-pharmacologic procedure. The following diagnostics were done with the following findings. Cranial CT scan plane shows multiple hyperdensities with surrounding edema of bilateral hemisphere, cerebral edema and other associated mass effects, acute intraparenchymal hemorrhages, thalamo-capsuloganglionic and right thalamo-capsuloganglionic areas, acute to subacute infarct with sign of hemorrhagic conversion at left coronary radiata, and both occipital lobes, atherosclerosis, mild polysinusitis, and partially sclerosed mastoids left. At this point of time, there was a note of a dilemma with the radiologist as to whether these lesions found are mass or bleed. Test AP shows suspicious density in the bilateral upper lungs. Pulmonary vascular markings are normal. Trachea is midline. The heart is not enlarged. The hemidiaphragm and claustrophrenic angles are intact, and the visualized osseous structures and the rest of the soft tissues are unremarkable. Consider pulmonary tuberculosis bilateral. Test X-ray, complete blood count was unremarkable. Coagulation tests are within normal range. Electrolytes are within normal range. Liver enzymes. EBG revealed respiratory alkalosis with more than adequate oxygenation at FiO2 100. Inflammatory markers shows an elevated D-dimer and LDH. An elevated D-dimer shows that patient is in hypercoagulable state. D-dimer is one of the major fibrin degradation products released upon cleavage of cross-linked fibrin by plasmid. On this patient, since he is a COVID suspect, the clinical use of D-dimer on this case is as a prognostic assessment in coronavirus disease. CD4 count noted only 6 cells per microliter. This single bit of information greatly increased the likelihood that the CNS manifestations are a direct consequence of immunosuppression. HIV-related opportunistic infection arise as a consequence of impaired immunity in advanced stage of HIV infection. Neurological involvement typically occurs in those with CD4 count less than 100 cells per cubic millimeter. Common CNS manifestation would include encephalitis due to infection with Toxoplasma gondii, HSV, or rarely VZV or CMV. Meningitis due to infection with Cryptococcus neoformans or myopterm tuberculosis. Progressive multifocal leukoencephalopathy due to infection with John Cunningham virus. Primary CNS lymphoma associated with Epstein-Barr virus. In addition, non-opportunistic infection, such as bacterial causes of meningitis, must be considered in patients presenting with acute neurological deterioration and infectious signs or symptoms. Please take note that although CD4 count were requested during admission, the said examination was only performed at a later date. Best practice guidelines recommend that investigation should be guided by history and physical examination findings. I am presenting to you a table summarizing the recommended laboratory workup for patient with altered mental status, vis-a-vis with what has been actually done to the patient. Plasma glucose should be the first test in any patients presenting with altered mental status. This was done by the admitting resident to our patient. Complete blood count to confirm suspected anemia and help in the diagnosis of infection. This was also done to our patient. Chemistry profile, including glucose levels, to rule out metabolic disturbances. This was also done to our patient. Thyroid function test if thyrotoxicosis or myxedema coma is suspected. This was not done to our patient, since the admitting resident did not find any information in the history that would support thyrotoxicosis. Urinalysis to rule out UTI was also done. Chest X-ray to help detect pneumonia, CHF, or other potential causes of hypoxia was done. Drug levels in patients on digoxin, lithium, quinidine, and alcohol was not done and not available in the facility, and it does not coincide with our history. The ECG and cardiac enzymes was also performed. ABG or pulse oximetry to evaluate for hypoxia and lactate commonly found in sepsis or hypercapnia was also done by the admitting resident. Lumbar puncture is recommended in the presence of nuchal rigidity and fever or if encephalitis is suspected. This was planned but was not carried out due to a finding of cerebral edema in the cranial CT scan. Hence, given this history, PE, and diagnostics, our present working impression is CNS infection, probably secondary to viral encephalitis, bacterial meningitis, TB meningitis, CVD bleed at left capsuloganglionic area and right thalamocapsuloganglionic areas, COVID-19 RT-PCR negative. Thus, patient is started on plain NSS 1 liter times 80 cc per hour. A third generation cephalosporin, ceftriaxone, was initiated. It works by inhibiting bacterial cell wall synthesis by binding to one or more of the penicillin binding protein, which in turn inhibits the final transpeptidation speed of peptidoglycan synthesis in bacterial cell wall. This causes bacteriostatic effect. For patients manifesting with CNS symptoms, an empiric dosing of 2 grams every 12 hours is recommended. During the patient stay at local district hospital, patient was indeed started with ceftriaxone, but only given once a day. Dexamethasone was also started to our patient. The guidelines suggest that adjunctive corticosteroids should be used for patients with mass effect related to focal brain lesions or edema. Dexamethasone 4 milligrams IVTT every 6 hours is the recommended dose and is generally tapered over several days. As to our patient, he was initiated with 6 milligrams IVOD. On the first hospital day, while patient is in the backlog, additional workup was requested. Blood culture and sensitivity was done, which eventually showed no growth for the next 5 days. He was also started empirically with cotrimoxazole 800 milligrams per 160 milligrams per tab, 2 tablets 2 times a day. Sulfamethoxazole belongs to an antibiotic classification, sulfonamides. It interferes with bacterial folic acid synthesis and growth. Trimethoprim inhibits dihydrofolic acid reduction to tetrahydrofolate, resulting in the sequential inhibition of enzymes of the folic acid pathway. ISDA recommends the treatment dose of oral and IV cotrimoxazole at 10 milligrams per kilograms per day TMP component in 2 divided doses for at least 6 weeks as an off-label use. As for our patient case, the dosing was adequate. On the second hospital day, a further decline in the GCS score was noted and patient decorticated. He was also persistently febrile. Due to an increase in breathing load and further decrease in the GCS score, airway was secured by intubation. A repeat chest X-ray was done, now revealing intercurrent pneumonia. An ABG was done post-intubation, revealing respiratory alkalosis with more than adequate oxygenation at FiO2 100 with computed requirement of 28.36. On hospital days 3 to 5, a further decline in the level of sensorium of the patient was noted. Meanwhile, hydration, nutrition, and medication were continued and maximized. Repeat CBC revealed normochromic anemia with no leukocytosis with adequate platelet count. We have noted mild hypernatremia with normal potassium, creatinine, and a slightly elevated BUN level. During the 5th hospital day, a sputum via ETA was requested for GSES with adequate specimen collection. The result came out and released days after and noted growth of Acinetobacter baumannii with the following sensitivity. The choice of antibiotics will be discussed later. Acinetobacter is a gram-negative Coccobacillus that has emerged from an organism of questionable pathogenicity to an infectious agent of importance to hospitals worldwide. And yes, ABAL is very popular in our facility. It is most notorious for its association with healthcare-associated infection. However, it has also been associated with community-acquired infections in Asia and Australia. On the 6th hospital day, patient was transferred in the ward and received the ward resident on duty. Noted GCS score of 7. A diffuse crocus preserved bilaterally with no neck vein engorgement. Baseline ABG was taken with patient's FiO2 set at 100%. Noted respiratory alkalosis with adequate oxygenation at FiO2 100, with FiO2 requirement of 80%. Since the FiO2 requirement is still elevated, FiO2 was maintained at 100%. IVF was shifted to D5.3 NaCl to compensate for the hypernatremia. N-acetylcysteine tablet was also given twice a day. The 7th hospital noted improvement in the level of sensorium of the patient from GCS7 to GCS10. Patient, however, noted to be tachypnic. A chest X-ray was requested and laboratories were requested to aid in the treatment plan. The trend of CBC now shows leukocytosis as compared to the previous CBC with neutrophilic predominance. This could be a sign of an ongoing secondary infection to the patient. Now, the hypernatremia was corrected and the rest of the electrolytes is within normal range. We, however, noted an elevation of LDH. Chest X-ray now shows new onset pneumonia. Given this data from the diagnostic and patient manifesting signs of pneumonia, patient was referred back to IDS and azithromycin was initiated. We can also notice that the patient was only referred to TB dots during this time, despite initial findings of a presumptive TB at chest X-ray. Antibiotics were also shifted to meropenem and amikacin, and antiepileptic medication was started, levetiracetam. HRCE planned to be initiated as soon as specimen for sputum gene expert is obtained. On the 10th hospital day, there was a note of improvement of the oxygenation status of the patient. An ABG was taken and noted respiratory alkalosis with more than adequate oxygenation at FiO2 100 with computed FiO2 requirement of 43%. Thus, FiO2 was gradually tapered and antibiotics were continued to be maintained. Only during hospital day 11 that this patient was referred to pulmonology service. The patient's GCS score now started to decrease. Dexamethasone was gradually tapered and FiO2 was increased to 50% due to desaturation episodes. On the 12th hospital day, patient self-extubated, initially tolerated, the laboratories were repeated and chest X-ray was repeated, revealing a repeat CBC showing that leukocytosis is resolved, but still with predominance of neutrophils. On repeat electrolytes, mild hyponatremia was noted. Repeat chest X-ray shows regression of pneumonia. On the 13th hospital day, patient was noted to be tachycardic, tachypnic, and febrile with note of seizure episodes. Patient was thus reintubated and attached to VR. an anticonvulsant medication, phenytoin, was started. Phenytoin stabilizes neuronal membranes and decreases seizure activity by increasing efflux or decreasing influx of sodium ions across cell membranes in the motor cortex during generation of nerve impulses. It should be given with a cardiac monitor at bedside, since it also prolongs effective refractory period and suppresses ventricular pacemaker automaticity, which shortens action potential in the heart. Loading dose of phenytoin for phenytoin-naive patient is set at 20 milligram per kilogram at a rate of 25 to 50 milligrams per minute in combination with the parenteral benzodiazepine under continuous cardiac and blood pressure monitoring. VR was initially set to 100% and gradually tapered to 40%. During the morning rounds on the 15th hospital day, patient was noted to be febrile with pertinent PE of RALs on both lung fields. Thus, VR setup was maintained and meropenem and amikacin was extended to 7 days more. At around 10:05 p.m. in the evening, patient was noted to be gasping with abrupt decrease in the level of sensorium to GCS3 and 4 and has been hypotensive. The resident in charge during that time considered mucus plug as a source of hypotension and decrease in the level of sensorium, causing the patient to be hypoxemic. So patient was reintubated. Inotropic support was initiated with norepinephrine and gradually increased dose until such time that dopamine and dobutamine were all maximized. At 12 a.m., patient was noted to be persistently hypotensive with fixed dilated pupils. Patient went into arrest. Resuscitative measures were done but was unsuccessful, and patient was pronounced clinically dead. At this point of time, do you have any clarifications from the consultants, doctors?
Was
Hello?
cranial scan done?
During this time, doctor, the cranial CT scan was not repeated.
Okay.
Hello, Martin. On the 15th day of hospitalization, you were entertaining the decrease in the sensorium and the rapid decrease of the blood pressure due to the mucus plug, no? So can you tell us, upon reintubation, is there any mucus plug?
According, doctor, to the resident in charge, there was no note of mucus plug during when the patient was extubated and reintubated, doctor. And also, there was no improvement in the vital signs of the patient after it, doctor.
So the decrease in the blood pressure was sudden, or is it a gradual decrease in the blood pressure as well as the sudden, the sensorium of the deterioration of the sensorium of the patient? Is it also sudden or gradual?
It was gradual, doctor. It actually started 3 days prior to demise. That patient, despite improvement in the levels of sensorium on the previous days, 3 days prior, the patient started to have to deteriorate in the level of sensorium, doctor. And the changes in the vital signs were only noted on the 16th hospital day, doctor.
So what would be the possible causes there, no? Since your hyponatremia was corrected, and then on the 15th hospital day, there was a gradual decrease in the blood pressure as well as the sensorium. What would be the possible causes metabolic, infection-wise? What do you think?
I think, doctor, it would be more of a combination of multiple factors, such as number one, we have already an existing central nervous system problem, which already has a mass effect on admission. And then this is also, I think the infection brought about by the ventilator-associated pneumonia with the growth of the ABOW could also have contributed to the deterioration, doctor, of the patient's clinical status. And the hypoxemia could have also contributed to the acceleration of the deterioration of the patient's status, doctor. So it could be more of a neurologic, infectious, although the metabolic was not that deranged. So the pulmonary could also have contributed to the deterioration of this patient, doctor.
Did you have any changes in the management of the patient? Since on the 10th to 15th day, before the 15th day, the patient is improving. Did you have any changes? I don't know if you just given the patient with mannitol, of course, given your dexamethasone. Did you have any changes on the management?
With that regards, doctor, there was no note of the change in the management, and actually the antibiotics were extended to another 7 days, doctor. But the only thing with that is that when patients started to have a decreased sensorium, we failed to repeat the cranial CT scan to determine to document the changes in the CNS status, doctor.
Okay, thank you.
Can we review again the initial cranial CT scan?
Okay, doctor. Here is the initial CT scan, doctor, of the patient. I will read the report. The official, actually, during this time, doctor, during the initial reading of this one, there was a note of that the radiologists find it hard, that the radio service find it hard to as to how to sign to read the patient CT scan. So they are considering either bleed or a or mass, as this is just a plain CT scan, doctor. So on admission, the detail is.
Can we run down? Can we view all and the plates? We'll review the plates. If there's herniation from the onset.
Doc, ang ilad, Doc, na ano, Doc, their finding, Doc, is, Doc, intraparenchymal hemorrhagic collections with surrounding edema at right capsuloganglionic area and left capsuloganglionic area. And there is a poorly defined hypodense areas with faint intersped gyral and sulcal hyperdensities are also seen in the left corona radiata and the cortical to subcortical areas of the bilateral occipital lobes. Most of the adjacent cerebral sulci are effaced, and there is minimal leftward subfalcine herniation of up to 0.3 centimeters, doctor.
If we review the scan, there's no impending herniation seen. Yeah, there's an edema, but edema is not that big, or that large enough to herniate the patient. And if we follow the course in the ward, there's improvement only on the latter part. Am I right?
Yes, doctor.
So I can't correlate that this herniating, this neuro problem would be the primary cause, the primary cause of the demise. So probably there are other factors. Yeah, there is an infection, but on the first scan, okay, it's not that severe, and there's improvement only on the latter part. Okay.
Noted, doctor. Thank you.
So there might be other factors that cause the deterioration of the patient.
Dr. Celis asked at the chat, what's the ABG when the patient deteriorated post intubation? I'm checking. So, doctor, post intubation, we note an ABG of
May I know what's the cause of hypotension?
During this time, doctor, the resident in charge considers hypoxemia as the cause of hypotension and sepsis as well, doctor.
Okay.
Hello, Mart.
Yes, doc.
Sorry, wala ako na-catch. May ABG na repeat?
Actually, doc, the ABG repeat was not taken.
Not done. Okay. Before the deterioration or reintubation, was there any ABG done?
During this day, doctor, there was no
okay.
doc, there's no ABG.
Ideally, you have mentioned that the resident was considering mucus plug. So actually the ABG can help you to know that indeed nga may ara siya, mucus plugging. Usually this would present with ano gani Marta, ang itsura sang ABG sang patient nga naga mucus plug. Ideally ano siya, naga acidosis or alkalosis?
Acidosis, doc.
Okay, so more on respiratory acidosis. No, so other causes of hypoxemia, especially kung there is decrease in perfusion, such as your hypotension, mga metabolic nga acidosis, ang usual nga ano niya sina. So if it could have been done, so we can readily help you kung anong cause sang hypoxemia niya.
Okay, doc. Thank you, doc.
Good morning, Mart. This is Dr. Romeo. Okay. So from the start of this course of the patient, you were entertaining possibility of CNS infection secondary to viral NSF, bacterial meningitis and TB meningitis, right?
Yes, doctor.
Okay. When you refer this patient to our IDS consultant, what was the gin-revise ang diagnosis for this patient with the aid na of the CT scan nga gin-discuss ninyo sa iya?
During admission, doc, it was to the IDS, doc, and it was noted that metronidazole was just started, doctor.
Ay, Mart, sorry do hindi ko kabati isang imong akon.
Doc, the CT scan was relayed to the CT scan was relayed to the IDS doctor during the time of admission, and there was no additional doctor. There was no additional medications given except for the metronidazole, doctor.
When was cotrimoxazole started?
It was started, doctor, on the first hospital day, doctor.
Okay, so it was started, this was referred to the IDS consultant, right?
Yes, doctor.
So at that time, what was the consideration why cotrimoxazole was started?
I think during this time, doctor, the CD4 count came in, and the consideration for CNS infection probably secondary to a the first entertained this way. I think it was the reason why cotrimoxazole treatment dose was initiated to the patient. Hindi
Come
given
again,
this,
Mart, sorry.
Doc,
Come
sorry.
again. The
Doc,
Sulfur was
Doc, the cotrimoxazole treatment dose was given to the was started when the patient's CD4 count came out, Doc, and the result was 6, Doctor.
so what was the consideration at that time?
Actually, it was not Doc, placed in the side notes, Doc, and I failed to
Yes,
discuss it with the admitting with the resident doctor. But the plans
okay.
for that is for AMS surveillance and to start the cotrimoxazole, Doctor. But I think the diagnosis was not updated during that time.
Yes, kay from what I understand from this presentation, no, though hindi ko kagawa ka relate from the start, no. So you have a multiple causes for your CNS infection. Is it a probable viral NSF, bacterial meningitis, TB meningitis? But during the
Yes.
course of your presentation, do wala kita sang clear cut kung ano gid nga primary CNS infection ang gina-entertain. When during the first or second hospital day that cotrimoxazole was started, with the results also of the CT scan, kung ako mag-analyze, the probability of a CNS toxoplasmosis was entertained in this case. Because if you want to treat CNS toxoplasmosis, you give it for 6 months for its acute therapy.
Okay.
Remember when we treat CNS toxoplasmosis, you empirically start it for a patient who is presumed to be immunocompromised with CD4 counts of less than 100, with signs and symptoms compatible with the CNS toxoplasmosis, like the bang patient presented with left-sided weakness, so those stroke-like symptoms, which could also be common sa patients with CNS toxoplasmosis. Plus, the history of I don't know kung ang CT scan kung gin-treat ang hambal mo to nga multiple high densities as a possible nga multiple mass lesions in the brain. So
Yes,
that's
Doctor.
why CNS toxoplasmosis was probably the diagnosis at that time when she was referred when he was referred to our ID specialist. Galing lang though nag-lost in translation kay this patient, I think was naglain-lain ang mga resident in charge. Though wala lang properly na endorse if what is this case.
Yes, Doc. Doc, I agree with that man, Doc. I actually, Doc,
no? Even when you accepted this patient, it was not clear to you kung ano gid ang primary nga CNS infection that we are treating for this patient, right?
Yes, Doctor. Yes, Doctor. Correct.
Okay, oo. So actually, this patient was referred to me only for antibiotic guidance for the pneumonia. When this patient was referred to me by the duty resident at that time, it was clear that the primary diagnosis that was entertained was CNS toxoplasmosis.
Yes,
but then during sa imong course of presentation, I haven't read, you haven't placed any differential diagnosis of CNS toxoplasmosis. So that's the reason why that cotrimoxazole during that time when this patient was referred to me, cotrimoxazole was continued as the primary drug for the CNS infection, and ceftriaxone at that time was shifted to meropenem because of Acinetobacter baumannii MDR pneumonia. Yes, okay. So since this is already a multi-drug resistant kay baumannii, so our best option would be to give carbapenem plus our amikacin at that time. And cotrimoxazole was maintained for the CNS toxoplasmosis. And at that time, it was also, we suggested that this patient be immediately referred sa TB dots for possible start of anti-TB
HRC.
regimen because sa X-ray may ara man siyang TB. So amo ning reason for for shifting of our antibiotics. I think on that March 10th hospital day, no?
Yes,
When this
doctor.
patient was admitted, ano siya gani nga GCS, Mark?
GCS 7, doctor.
GCS 7. Then eventually sang day 10, sang day 10, nag-increase siya to GCS 10 man siya.
10, yes, doctor.
Okay. Remember, for patients also, no, kung wherein we consider this as a possible nga cerebral toxoplasmosis, they are highly responsive to our cotrimoxazole. And usually, in a span of 7 to 14 days, we can see improvement na on this case, no? Kaya hambang nila, if this patient will not improve in the next 10 to 14 days, so there's a possibility of doing biopsy for those mass lesions to determine other causes other than toxoplasmosis. But usually, no, kung toxoplasmosis lang, we don't do biopsy of those mass lesions because one of the guide na makahambal kitaan possible ni siya nga cerebral toxoplasmosis if nag-improve ang iya condition on the 7th to 10th day of cotrimoxazole. So my question is, was cotrimoxazole given on this patient? Or basi wala na hatag? Or may mga nang wala compliance with cotrimoxazole?
Actually, doc, if we review the medication history of this patient, it was given, doc, to the patient.
Okay. So when sang day 10 siya, day ano siya sang iya nga cotrimoxazole? Kasi sometimes no naga-order kita sa chart but then wala bala mahatag ang mga bulong
Yes,
how.
Sige, doc. On the end, doc, actually, doc, the cotrimoxazole was started on July 30. So that's around day 10, hospital day 10, that's around day 9, doc. Day 8 to 9, doc. Yes,
okay. Okay.
Cotrimoxazole.
So, but then no, ang question lang, what happened sa day 11 when this patient again had further decrease in the sensorium? Amo lang ang daw hindi ko man tuod ma-explain. Hindi ko ma-explain to ang after sang day 10 when there was a further decrease in the sensorium of this patient. Okay. So for this case, no, so viral encephalitis was probably not a diagnosis for this. Bacterial meningitis, kagaling kayo, better man gituod kung naka-lumbar tap, but then because of the presence of the cerebral edema, multiple brain lesions, which is very, nang risky for this patient. So, ako I agree man to defer the procedure. TB meningitis would be one of the differentials, but then the presence of those lesions of brain could explain the TB meningitis for this patient.
And
so,
I think
though less likely, no, ang TB meningitis with the presence of those lesions sa aton CT scan. Did you have any Mark ng discussions with regards sa makita natin sa CT scan for patients with cerebral toxoplasmosis? Example.
For the
common ang hemorrhages. I have also come up, I don't know kay Doc Abad if kung may mga cases before siya nga na encounter nga wherein cerebral toxoplasmosis could have also pwede mag-present also with brain hemorrhage. Kay may nakitaan ako nga one of the article wherein hemorrhage may be seen occasionally in patients with toxoplasmosis. So I don't know kung galing wala kita repeat scan mo, no, ideally tani nagpa-repeat scan kita to determine kung nag-improve ang aton nga or basi nag-progress kagid or what happened to those mga hemorrhagic nga ano no nga lesion sa aton nga brain. It would, I don't know kung nagka-contribute man sa demise of this patient aside from the sepsis that we consider, which could be number one, secondary sa iyang primarily secondary sa iyang Acinetobacter nga pneumonia. Okay. So that would be all my inputs. Thank you.
Thank you, doctor. So with regards to the imaging, doctor, no, so MRI is the imaging modality of choice for evaluating patients with possible toxoplasmosis. And most AIDS patients with TE would present with a multiple ring-enhancing brain lesion, often associated with edema. And this was actually the reason that when these findings were relayed to Dr. Abad, so the toxoplasmosis was entertained, doctor, no? And as compared to our findings in to our CT scan findings in the TB meningitis, doctor. So radiographically, they would present as discrete ring-enhancing lesion of the brain surrounded by perilesional edema that may be single or multiple, doctor. So those lesions, I think, I just don't know what the exact picture of this in the CT scan, doctor, but the descriptions would somehow we could say that they are comparable with toxoplasmosis or maybe TB, Dr. CNS TB.
Mark, actually,
Yes,
we
doctor.
come up with the possible, no, but not definitive toxoplasmosis based on the background of possible immunocompromised host, diba?
Yes, doctor.
But we
Doctor.
don't rely it on the CT scan, right?
Yes,
Because
doctor.
the CT scan alone could not support, the toxoplasmosis. If ever there's some repeat scan with contrast, probably, but usually in the CT scan, you can see enhancement following administration of contrast. Now you can see nodular and ring enhancement, which is typically thin and smooth. And double dose delayed scan may show central filling and calcification may be seen. So sometimes we could ask for MRI, but it's still difficult to identify, no? Even with T1, T2, but usually we can request for MR spectroscopy to see if there's increase in lactate, increase in lipid, reduced NAA, increased lipid lactate. So the treatment is usually based on biopsy, but in this case, di naman natin give na the ubra, and it could not, the biopsy might not be required, and treatment should be initiated following imaging imaging scan. But an exception in this case is kung atypical ang presentation in the imaging, then biopsy is required. Okay, so this is not really na mambal naton na really it's a toxoplasmosis, no? But we just base it sa multiple and in the background of immunocompromise, but we have other differential diagnosis. And besides, as mentioned with Dr. Pareño, so wala siya nag-improve, no, with the medication for toxoplasmosis, right? So there might be other na possible etiologic agent or factors that give rise to the CT scan findings. So other possible would be CNS lymphoma, okay, tuberculoma, cryptococcosis, okay, or initial bacterial abscess. Okay, so hello.
Yes, doctor. Thank you,
Oh,
doctor.
yeah. So it's so difficult, no? But sa last nga parts ng patient wherein there's a rapid deterioration, so I could not say that it's a primary talaga neurological unless there were repeat cranial CT scan, no? Tapos nag-hypotension and all with the background of infection also in the systemic area. So this could be a multiple factor, but we have to dig more, know more kung ano tong lesion sa brain niya, no, in the background of an immunocompromised host. Okay.
Thank you, Doctor.
Thank you.
Indeed, Doctor, that is one of the challenges now as we manage this patient, because we have just been treating these patients empirically and based on the given history and patient's present immunologic status, Doctor. I think that is also the reason why the ward resident that time did not sign up the patient just on one specific cause na toxoplasma, but also considered TB meningitis and bacterial meningitis as a possible differential or possible cause of the patient's neurostatus. So if may mga clarifications to Doctor, thank you for the inputs, Dr. Pareño and Dr. Abado and Dr. Celis. So if there are no other questions, so we will now proceed with the factors contributing to the demise. So as to the patient had an active lifestyle with unprotected sex with multiple partners and being high risk to HIV infection. Still no consult was made and no previous screening for HIV were done. And the access to healthcare is limited and late given the present pandemic situation and the societal factors that could also have contributed to the patient's access to healthcare. And we have received the patient with poor prognosis at the time of admission. So another factors that would contribute to the demise is during the initial assessment, sound treatment plan is anchored in a competent history taking. And some important points that need to be asked in the history were missed. MMSE was not performed and was not, if performed, it was not placed in the chart. It should have been one of the important baseline. And some important physical assessment were missed, like the detailed neurologic assessment and meningeal signs should have been elicited. For the diagnostics, so the admitting resident has requested almost all labs and diagnostics necessary to investigate the cause of altered mental status. But some diagnostic exams were, due to existing policies, were carried out very late. And we could take note that considering that this patient, we are considering a lot of and differential diagnosis for this patient. So we don't have available laboratory or serology studies for that. No? So the lumbar tap was not also performed as it is contraindicated on the patient. No, other serologic tests either to confirm toxoplasmic encephalitis, like the toxogon IgG, cannot be found in our laboratory. No? And official resorts of important imaging modalities, such as cranial CT scan, were released late. So, other factors contributing to the demise, we have underdosage of ceftriaxone from referring hospitals. The initial dosage of dexamethasone on admission is not a recommended dose. And we have noticed, we have also take note late referral to pulmonology service and the other commanding service, especially the IDS service. Other factors contributing to the demise are as follows. So, patient endorsement and handing over of care to next residents, since there are many residents involved, is sometimes inadequate. Receiving resident would usually call endorsing resident to clarify pertinent clinical information and other information. And the coordination of care to other services is non-systematic and unorganized, and miscommunications would usually ensue. Since there are a lot of patients in the non-COVID ward, in the non-COVID setting, with limited number of residents during that time, the volume of activity or workload also contributed to the demise and quality of care, not just in the medical aspect, but as to also to the nursing aspect and other members of the healthcare handling the patient. We also noted delays or failures to involve other consultants in care. And there was also a poor recognition of change in clinical status, causing delay or failure to recognize changing clinical signs and symptoms and improve or modify treatment plans. So these are the factors, doctor, that I have considered to be contributing to the demise. So are there other recommendations from consultants and other residents on how would we able to improve patient care to these patients? So I think the recommendations earlier was also well said, doctors. So we are presented with the case of a 42-year-old male who came in due to altered mental status. A history and PE was done to identify cues on the possible etiology of altered mental sensorium based on the timeline of the progression of disease process and other factors. We have emphasized that this male is living with a partner, but at the same time has multiple sexual partners, which is an important piece of information, increasing the likelihood of an immunocompromised host. Baseline diagnostics were taken like cranial CT scan, which showed multiple hyperdensities with surrounding edema, and it also shows mass effect. This is in the background of a CD4 count of only 6. Thus, therapeutics were directed towards preventing or treating secondary infection and primary infection. So a treatment dose of cotrimoxazole was given, and patient also went through ventilatory support. Due to multiple factors, including poor prognosis at the time of admission, and other factors such as sepsis, secondary infection, patient eventually succumbed to death. And we also ended up the discussion with the factors affecting the demise and the recommendations thereafter. For my take-home message, number one, utmost confidentiality of the given information and discussion. Number two, a solid plan always start with a systematic, organized, and focused history taking and physical examination. I also recommend to utilize readily available guidelines and journals in providing care, and an organized workflow for patient care would almost always end with a better outcome. We learn from our mistakes. This will make us a better internist.
Hello, Dr. Palco. What is your exit diagnosis, and you don't have any discussion regarding even as a brief discussion about the case of the patient?
The patient was signed out as septic, as the patient was signed out as septic shock secondary to central nervous system infection secondary to toxoplasmosis, toxoplasma gondii, number two bacterial meningitis, number three TB meningitis, and immunocompromised host. Ventilator associated pneumonia secondary to Ebola infection, electrolyte imbalance secondary, status post intubation, doctor.
Mark, ang toxoplasmosis siguro mas better i-out kaya hindi man kita definite sa toxoplasmosis. Hello?
Hello, Doc.
Yeah, oo. Secondary to toxoplasmosis. Bisang mga final diagnosis.
Ano siya, Doc? Actually, Doc, tatlo siya, Doc, Doc. Bali, septic shock, secondary to central nervous system infection, probably secondary to, number one, toxoplasmosis, number two, bacterial meningitis, number three, Doc, TB meningitis.
Sige, okay.
In a setting of an immunocompromised host, Doc.
Sige, okay. I agree.
Martin, for the benefits of everyone, no, if it is really a AIDS, no. So when are you going to initiate a TB treatment?
Doctor, TB treatment should be initiated, Doctor, based on the clinical suspicion of TB. For example, if the patient shows an active disease, so we should initiate already, Doctor, HRZE. But if it's presumptive, we will start with IPT treatment prior to the initiation of doctor of ARV.
Come again,
After the
Mark.
doc, hello doc.
Come again. If it is a TB infection, we opt to give IPT.
HRZE, doctor.
Okay, sige, that's good. If it's a TB infection, we opt to give, ang earliest is 2 weeks after you start your anti-TB regimen. We do not give ARV or antiretroviral therapy prior to our TB infection because of fear of the immune reconstitution eventually for this patient. So meaning, nag-flare up ang TB naton if we give ARV right away for this patient. So we need to control first the infection before we give our antiretroviral treatment. If we are going to give, if we are treating this patient as a toxoplasmosis, for example, kung cerebral toxoplasmosis siya, we will wait after the end of the acute phase of treatment, which is 6 weeks. That's why amo tong ginbutang siguro ni Doc sang aton nga ID consultant nga cotrimoxazole for 6 weeks. Because I presume after 6 weeks, this patient, if proven nga HIV siya, this patient will be started with with our antiretroviral treatment. Sige, so that's why kung TB, ang treatment is 2 weeks. Pero kung actually depende man pagid ni siya gali sa aton nga CD4 count, no? Kung higher ang iyang CD4 count, if this patient can wait for at least ma-finish siya ang aton nga first phase of treatment, which is the first 2 months of treatment, better. But if very, very low ang iya CD4 count, so earliest to give the antiretroviral therapy for this TB patient is after 2 weeks of treatment. Okay. With regards naman sa IPP, because sometimes no aton nga mga residents I observed no sa OPD, wala TB ang patient clinical wise, by X-ray wala man siya TB, by sputum exam, sputum gene expert negative for TB, they give by our guidelines we give IPT or isoniazid preventive therapy. I observed that nagapahatag kita IPT for 2 weeks before we start with ARV. So remember, IPT is not a treatment, it's a prophylactic medication. So you can right away start with ARV if you think that this patient has no active TB. No, we don't need to wait for 2 weeks of IPT before we start this patient on antiretroviral therapy. Thank you.
Thank you, doctor.
Mark, ask ko na, nakapa-blood culture gali kita.
Yes, doc. Nakapa-blood culture, doc, ang on the day of admission, doc, and was not repeated, doc. Pero ang blood culture, doc, on the day of admission shows no growth, doc, up to 5 days of incubation.
Okay, sige. Copy. Thank you. Thank you, Mark.
Hello, doc.
I would like to congratulate the presenter, Dr. Palco, for the thorough discussion of his mortality conference. Also, thank you to our consultants for sharing with us their expertise regarding this case, Dr. Parenio, Dr. Abad, Dr. Celis, and Dr. Fabila. Dr. Mart, you can close your presentation now.
Thank you, Doctor. So I would like to thank everybody who is present here, and to all our consultants, fellow residents, and PGI. I hope that we have learned something from today. Thank you very much, doctors.